Hi, listeners. This is a quick thank you for listening and for your ongoing support. If you're enjoying the program, please consider clicking the follow or subscribe button if you haven't done so already. It really helps us out. There's no better way to support us than doing that or sharing the show with a friend, colleague, family member, or any new or expecting parent in your life. It's totally appreciated. On with the show. Hi, I'm Sarah Trott, and welcome to the Fourth Trimester Podcast. I'm a new mama, and this podcast is all about postpartum care for the first few months following birth, the time period also known as the fourth trimester. My postpartum doula, Esther Gallagher, is my co-host. She's a mother, grandmother, perinatal educator, birth and postpartum care provider. Fourth trimester care, our topic, is about the practical, emotional, and social support parents and baby require. And importantly, it helps set the tone for the continuing journey of parenting. Hi, this is Sarah Trott. Welcome back to the Fourth Trimester Podcast. Today, I have a special guest, Dr. Ed Stevens. Dr. Ed Stevens is an internationally recognized physician and psychiatrist who specializes and has specialized in men's mental health over a lifetime of practice as a psychiatrist. And along with the other professionals from many disciplines and all walks of life, he has championed initiatives to counter health, education, and the overall social decline of men and boys over the last 50 years. And most recently, he has been working on a really exciting project, a document, which is a medical document, a questionnaire called Bringing the Father into Pregnancy. And we're very excited to be talking to Ed today about this document. I also want to mention a little bit more about Dr. Stevens. He created the Foundation for Male Studies, and he did this to promote an apolitical and academic study of all things male. And he will be the first to tell you that's MALE, not MAIL. And he has used his special insights as a physician, along with a particular interest in family, to pioneer the study of depression in men and the specific needs of fathers around the birth process. So we're thrilled to have him on the program today. Welcome, Dr. Ed Stevens.
Well, thank you, Sarah. That was a very warm and, I think, a comprehensive view. So thank you.
Yeah. Well, I would love to invite you to introduce yourself in your own words.
Well, when people would come into my office in the latter part of my practice, I would say, I was sitting in this chair working as a psychiatrist before you were born, so you better listen. And I said, where did you train? I said, I learned everything I know in this office, talking to patients. So I think those are the two notes I'll add. But in regard to my work, both with men and in regard to this work with postpartum depression and the circumstance around birth and delivery and men's participation in it, I learned that the hard way too. From having my own kids and having my own postpartum depression and not being able to find any help. I mean, one of the problems for men is there are very, very few resources. So that's really what got me started. I tried to work from my experience of loss, of difficulty, and instead of feeling lost and difficult, I tried to turn it into something useful. I said, how can I make a difference here? My work really, whether it's been with the individual patients or in this larger sphere in regard to trying to help men and boys or help in and around this obstetrical situation. How can I make it better? That's been my mantra.
Yeah. And what an inspiration for your work than your own lived experience. And tell me more about that. So you're a father. You mentioned you had postpartum depression. Did you even know to call it that at the time, or how did you realize that you were in that place?
I did not realize I was there. And even though I was in therapy with a senior psychiatrist, he didn't realize I was there. We looked at it mostly, and I felt it mostly as a moral failing. I had been hypomanic, and I had gotten myself into some compromising situations. And then after I discovered my wife was depressed, she was reading a book why I hate pregnancy. I was exuberant. I was hypomanic at the idea of, at the age of 40, having my first acknowledged child, and my wife is depressed. So I was getting it from all directions. I was getting both juiced because of the pregnancy and hammered because of the wife's depression. So I really, really, really had a very bad time, and I got zero help from the professionals at the time. As a matter of fact, it took me until probably about 20 years ago to begin seeing articles in the literature about depression in men in and around pregnancy. And there were, for every article on women's difficulties, emotional difficulties, there might be one article on men for every 15 articles. But I kept following them, and over the years, as it became, a greater and greater interest of the community, and then I have a what I think is a cute way of just saying, "And finally, they discovered depression in men. It's a discovery." The disease has been there from time immemorial, but they discovered it. They discovered we suffer, you know? We're not supposed to suffer. So, that's a little bit of it.
So it was a discovery for you and for the whole world. But why aren't people talking about it? I see modern statistics around 1 in 10 men, 1 in 5 women. Is this just because of the reporting and the attention, or what? There's a disparity there.
Well, we get so much bad press as men, I mean, I'm surprised you're even interviewing me because, I might have a little bit of toxic male in me or something, especially since I'm interested in men and boys, You don't know what to expect. But, we just have fallen off the radar. And, we can also attribute it in some respects, in this case, around pregnancy, labor, and delivery to um, a really major failing in the medical system because while a man is 50% of the generic combination with the mother in the fetus, and he brings his own epigenetic. Epigenetic means all the life experience that pushes him one way or another. He brings that into the pregnancy. So he's a full contributor to the pregnancy. But when you start out and you go to the first obstetrical visit, I call it the first well care visit, the father, he's transportation. He brings the mother there. The mother goes in and sees the doctor. The doctor takes a medical record, examines the mother, gives her vitamins and blah, blah, blah. And then she comes out, and maybe the doctor comes out and congratulates the father, and then they go home together. And then if he comes back to a second visit, he's again a visitor. Well, I said, wait a minute, there's something wrong with this because the father is half of this. It's really the way I like to put it. I talk about the pregnant father. Now, some people have told me, you can't talk about the pregnant father. That's almost disparaging of the mother. No, the damn father is pregnant too. If you've been a father, you know. So I said, wait a minute, there's something wrong with this. We've got to bring the father into pregnancy. And the way to do it is to change the paradigm, meaning to change the way it's done. So after reading, and thinking about this, and I went to the World Association for Infant Mental Health in 2023, and I presented a proposal that I would do a meta-analysis of the literature, meaning go through all the literature and come up with the information needed to make sense out of this. And I did that between 2020 and 2024. I went back to the World Association of Mental Health and presented a completed questionnaire for the father for before pregnancy and after delivery that is to be given to the father when he shows up at that first well care visit. So the father becomes part of the official record. The father isn't in the waiting room. The father is in the room. And we now have a mother, child, father, holistic approach to pregnancy.
And Jane Hodgman, who so kindly introduced the two of us, Ed, what does she have to say about this?
Well, Jane has been working on this for almost as long as I've been a psychiatrist. And so when I sent this to her, she said, it was an OMG moment. She said, "This is what we've been waiting for. This is what we've been looking for," because the Postpartum International, wonderful, wonderful organization, was matrilineal, matricentric. In other words, mother-centered, mother and child-centered, just as was the medical approach. I call it myopic, which means short-sighted. And so when she got this, she said, "This is what we need." And she, she embraced me warmly over the phone, and we've been working together since then.
It makes sense, right?
Well, wait a minute. It makes sense. That's an interesting observation.
Yes.
When I showed this to my wife, who's a psychologist, she said, "It has face validity." I said, "What's that?" "It just looks good." It makes sense. Everybody that reads it makes sense. So I did something that makes sense.
I mean, this is the culmination of so much work in your own experience. And as you said, you want to make things better for other people. I'm so excited that you're doing this work and you're bringing this research. And tell me more about what's in it. What is in bringing the father into pregnancy?
I think you just touched on something that's very important. It is it I really feel this to be the culmination of my life's work as a physician, starting out in obstetrics, where we had so many psychiatric consultations that we called on the mothers because they had a lot of distress. I saw how the psychiatrist worked, and I liked it. I liked it so much, I changed my specialty from obstetrics to psychiatry. I said, "I wanna do this. I wanna be able to make this difference in the lives of people." And, so that was in, believe it or not, 1967. That was before you were born.
Correct.
Before you were born. So I moved into psychiatry, and then I had in 1978, I had my own birth experiences, which were utterly traumatic because I had a special needs child as well. That's another element. And then all these years from 78 through 2000, I'm working on male issues, and it's not until maybe about 6 or 7 years ago I really began to put it together. So my initially in obstetrics and gynecology, then my work in psychiatry, it all came together in this last 5 years. So this really, when sometimes one wonders what it all means, but I think that, I've been led here. I've had a calling.
I mean, it sounds like it. It sounds like you sure have.
And not only that, you can see from the way I'm presenting this, I've had a lot of fun along the way.
Well, that's just the best way to do it, right?
Yeah.
Yeah, you might as well enjoy it. So then this document, we want to get this into the hands of all of the providers who are managing these well care visits.
That's it, exactly. What I want it to be, Sarah. Now, my wife looks a little askance at me when I say things like this. "I want this to be like polio vaccine. I want it to save lives." Well, if you stop and think about it, a document like this has such potential for good because, you mentioned the 10% of men and God knows, conservative will say 10% of women, but that usually pushes higher, maybe 15%. Well, 10 plus 15 is 25, and if one has it, there's a 50% chance the other has it. So every pregnancy has about a 25% chance of there being a significant emotional component that has a bad effect on the mother, on the pregnancy itself, on the
Mm.
child, on the child's mental health. So getting this document embedded as standard practice in pregnancy, America and the English-speaking world is one thing, but this has applications all over the place. I mean, this bringing father into pregnancy, wherever there's a father, whenever there's a pregnancy. This works.
Absolutely.
So when my wife looks askance at me about my reference to polio, I say, "Well, you'll see."
And what's in the document itself?
Well, it's very simple. The American College of Obstetrics and Gynecology, we'll call it ACOG for short, the official specialty group for people working in obstetrics. They have a standard form that's given to every mother at the well care visit. It takes her medical history, and then it goes on and takes a lot of other history, and then they examine her and whatnot. Well, I looked at this form and I said, "Something's missing. Where's Papa?" Because nowhere in the form is the father included in any way at all. I mean, his medical history isn't included, his psychological history is included, his epigenetic history. I said, "There's something wrong with this. The father is 50% of this pregnancy." So what I did was I took that document, the official document of the American College of Obstetrics and Gynecology, I just took it and I started off with a medical history for the father. And then, because we know how important the psychology of pregnancy is and the emotional component of it is for everyone, I then went on and through the research for the literature that I mentioned, I created a list of questions for the father at that first visit that would give some indication of the likelihood that the father is going to have difficulties. And I said, if the father answers yes to a single question, for instance, are you under 25? Automatic yes. That says has a risk for depression or emotional disturbance. Do you have job security? Whoa. Do you have an intimate relationship with your wife? Can you talk to Are you in agreement about the pregnancy?
Mm.
Is this a planned pregnancy? But these are all the questions that are being asked of the father. Now, you know, his answers to that, if he answers to yes to one, there's a likelihood he answers to uh, to two questions positively. There's a greater like if he answers three, he's almost bound to have this peripartum, postpartum depression. So what it does, it's like a screening device, but it's such a wonderful tool because it's not just a screening device for the father, but since everything that happens with the father has an effect on the mother, it's also a screening device for the mother. And if the father says, "No, we didn't plan for this, and we haven't talked about it," well, isn't this the most wonderful opportunity in the world? Because now we can start planning and talking. And so I say the well care practitioner. I call it the WCP. The well care practitioner. It could be a nurse. It could be a midwife. It could be a doula. It could be an actual physician. Now has a chance to really understand the full picture and see not just what's going on with the mother, but seeing what's going on with the father that is going to affect the mother.
Mhm.
Well, that's it in a nutshell, but
Does it touch on the mental health history of the father as well
well, it's good you
and
asked.
his family?
It says one of the questions is, have you had mental or emotional problems in the
Mm,
past? Do you have a
yeah,
history of mental or emotional problems? Have you had recent losses or significant losses in the past?
yeah.
So in other words, or here's one about adverse childhood experiences called ACEs. Have you had any adverse childhood experiences? God knows all kinds of things happen to boys like everything else. But then when the pregnancy comes along and they're thinking of starting a family, it all comes flooding back. Their experience of family, their experience of their life. My God. So it's really quite a sweeping, I'd say, inventory of possible difficulties. And Sarah, and I'm giving you the finger now. When I give the finger, this is the finger, all right? That's like
He's holding up his pointer finger for those who are audio listeners.
I'd say to my patient, "I'm giving you the finger now." Well, the idea is that this questionnaire, for every difficulty that it surfaces an equal or perhaps even greater number of possibilities.
Yeah.
Because when you identify a difficulty, you already have a leg up on it. An ounce of prevention is worth a pound of cure. More so here than any place else because there's so much at stake. The
Yeah.
well-being of the mother is at stake, and the very well-being of the child in terms of the pregnancy itself. These kinds of upsets in pregnancy cause premature delivery or depression in the child. If the father has depression, the mother has depression, there's really increased likelihood of depression in a child, not just in the short term after birth, but also in later on in the child's life. So this is really a screening tool that has just unlimited potential for good, for prevention, for intervention.
We've had childhood education professionals come onto this program and talk about brain development in infants and how that relates to connection. And if someone is feeling depressed or anxious, that might be a challenge for them to connect with their infant.
Well, that's the hallmark of postpartum depression that it interferes with the connection between the mother and the child if it happens in the woman, or the father and the child if it happens
Right.
in the man, or the father and the mother and the child. Some of the items on the list have to do with the father's very personal experience of the pregnancy because there's an enormous shift of focus from the couple paying attention to each other to the mother paying attention to these enormous changes that are happening, and then the pregnancy itself, and so fathers very often feel left out, and so there are enormous psychological adjustments that have to be made.
Yes, and I've also heard statistics around divorce rates and how those can increase after the period right after having a baby. That's also perhaps related to this additional stress and the psychology around the changes.
All right, you mentioned divorce, well, in other words, we tend to idealize pregnancy, but basically every pregnancy is an absolute intrusion into our lives. We never knew we had it so good until we had a baby come into our lives. Then we never knew we had it so good, but we never knew there was so much work. And so it puts a strain on the relationship. And
Mhm.
that's where if there are difficulties in the relationship, it shows up and can show up in divorce. But, I'm gonna get a little grim here because recently there's been a lot of information about matricide, mothers being killed, mothers of young infants being killed. And my own take on this is that there's been a lot of undiscovered depression in the male partners of a lot of these women who have been murdered. So this is an extraordinarily important screening device.
Well, life-saving potentially.
Yes, yes, life-saving. Now you mentioned brain development.
Mm.
Brain development in the infant really depends on the capacity of the parents to connect and to nurture. And anything that interferes with attachment, meaning the ability of the father or the mother to feel that deep, deep, deep connection to the child and impart that nurturing, that really detracts from the development of the child. So we're really touching on uh, the heart of the matter here in this holistic approach that has healing potential for the father, for the mother, for the relationship, and protective potential for the child.
Hey, listeners, great news. We've partnered with Every Mother, your go to destination for evidence based and on demand exercise therapy regimens. Whether you're dealing with diastasis recti, preparing for birth, or navigating postpartum recovery, Every Mother has your back. With personalized daily routines tailored to your core and pelvic floor needs, they're here to support you every step of the way. Say hello to a stronger, healthier you with Every Mother. Visit fourthtrimesterpodcast.com/everymother for 10% off your personalized express exercise routine. The discount link is also on our deals page alongside lots of other amazing exclusive discounts and deals. Again, it's fourthtrimesterpodcast.com with fourth spelled out Fourth. Yeah. And I appreciate that what you're talking about is the whole picture, right? So you're Ed Stevens, founder of Male Studies Institutions, right? But you're
MALE.
MALE. But like, are you a feminist? You're not saying like what I'm hearing is that you're not saying mental health for men is more important or mental health for women or any particular group is more important. You're talking about the whole picture.
Well, if anyone gets to the site for male studies, what they'll see is in everything I write, everything I promote
Mm,
is really for the well-being of all.
yeah.
So while I'm promoting, incentives and initiatives for men, it really is for all of us. So you can see in this questionnaire for the fathers, it has so much benefit for the mother. It's for
Yeah.
all of us. And you see, that's where when we get a little too gendered, we forget
Yeah.
that just as I talked about the pregnant father, and then I talked about the mother, fetus, father complex in the pregnancy, I think that we have to remember that you're over there, I'm over here, I'm a male and you're a female. But the way I put it is we walk on two legs. If we don't walk on two legs, we limp.
Yeah.
And the two legs are male, female. So I see male, female as, or female, male as a unit. I don't see males as a separate unit and females as a separate unit. I see male, female as our pair bond.
You're not picking one gender over the other. And you've also acknowledged the importance of a questionnaire like this for even same sex couples.
Oh, now this is interesting because the way I've envisioned this is the mother comes, ideally, she comes with the father, and the father is brought in and, he's given the questionnaire and he becomes part of the medical record. But say the father doesn't show up. Well, the mother is given the questionnaire to take home to him to fill out. But the mother is given the questionnaire to fill out even if the father is an absent father or a father who doesn't want to have anything to do with the pregnancy. Or the question is equally valid for significant others, for same-sex partners. Now, while the same-sex partner won't have the biologic investment in the pregnancy, they will have every bit as much epigenetic impact on the pregnancy. So, in other words, this questionnaire is really for anyone and everyone who is intimately connected with the pregnancy.
Absolutely. Yeah, I appreciate you providing that additional context. And when you were describing some of the questions to me, it's very personal information. Sometimes people might be nervous to share so much. Do you think that there might be cases where people who are filling it out might not want to tell the truth or might try to skip over it because they just have a hard time opening up? What would you say to that person? We want people to fill
Now,
this out honestly and openly.
in the questionnaire,
Yeah.
no one no one has to divulge anything. It's just check the box, check the box. I'm under 25, check the box. I have job insecurity, check the box. This is not a planned pregnancy, check the box. All you do is check the boxes. Now, then the well care provider looks at this and says, whoa, we have to think about this. And every pregnancy is connected to a social service component. So this information can simply be passed over to the social worker or whoever is doing the support. Now, there is also the situation where it may be very rural and there may not be any social service involved. Well, after the question is filled out, the well care provider looks at it and says, there are really some things here that need to be looked into. And, have you talked to your husband about this or that? So, as you put it, it's a door opener. And beyond that, one of the other questions is, do you feel you have family support? So, absent professional support in the form of a social worker, the well care provider can say, is your family involved? Your mother, your father, are they happy about this? So, in other words, bring them in. And, it's really, if we stop and think about any pregnancy, there are many stakeholders. A stakeholder is someone who's involved. Every pregnancy touches not just the mother and the father, but touches their mother and father, their aunts and uncles, the extended family, and friends. Baby showers are given by friends, and they're big events, big events. I want baby showers for fathers. I don't want stag parties. I want baby showers for fathers. So you see how this absolutely opens the door for all possible avenues of support and conversation. And as I said, for every difficulty that is unearthed, there are possibilities both for remediation and for augmentation, make it better. Now, if I said it to my wife, she'd say, "Look, but here I am. I have a general audience, so I expect someone out there is going to get it, you know?"
Well, what can families do, in your opinion? You've got so much wisdom, so much experience. You've created this wonderful document. I'm just wondering what you think families can do to help solidify their relationships and their mental health so that we see more success for families.
Well, you know, every one of us, and this is from my work as a psychiatrist, has their capacity. People came into me and some would be highly educated, some would be high school dropouts, and some would be, psychologically, obtuse, meaning they didn't get it. So every couple has to start where they are, and the well care provider gets a sense of where they are as they encounter the individual. You mentioned the well care provider says, "Well, you check this off, and that's often a problem." Well, it's not gonna be a problem for me. Well, that already says that the father is really not particularly psychologically attuned or not well adapted to looking into the complexities which he's going to face, whether he wants to or not. But in my practice, my model was this: I didn't care who came to me or what their resources were intellectually, educationally, or financially. My motto was I was going to try and work with that person to bring them to the greatest possible fulfillment of themselves that I could arrive at with them, with their education, with their resources. In other words, we take what we've got. If you got flour, water, and blueberries, you make blueberry pancakes. You can't make a roast turkey.
So you're making the most, right? Everyone can make the most of what they have given their circumstances. You said earlier, just naming an issue helps address it, right? You
Yes.
got to start somewhere. And when we talked beforehand, before we started recording, we were doing some prep for the session. You said people need to be exposed to good ideas, good experiences, warm, empathetic people in order to learn and to translate experience into their skills and learning. So tell me more. What do you mean by that?
When I go over this long journey of learning that I have been on, because by the way, I'm still learning. I mean, today, before we started this session, You introduced me to, Chrome and how to get there, and you walked me through it, so I'm still learning. I reflected that it was very often the people in my life that brought me along in terms of my understanding of the meaning of life and my ability to live life well. And they didn't do it by, so to speak, giving me a lesson. They didn't do it by teaching. They they did it by living it out in front of me. And in my practice as a psychiatrist, I've tried to do that. I've tried to live out this, I would say, large view of the world, of the people I work with, to be non-judgmental, to be hopeful. The when someone would come to me, I never knew where we would end up. And by the way, I've worked with people for 10, 15, 20 years. I've even worked with someone for 40 years. So I never knew where they were going to wind up. But it was, I felt, not my book learning that I was going to translate. It was the encounter with me as a developed person. In other words, when you sit down with someone who has a sense of what's going on, they don't teach you that. Now, look, I want you to, do 1, 2, and 3. No, they don't do that. They just by being with them, your vision broadens. And I like to say that once a mind has been enlightened by an idea, it never goes dark. Or I like to say, I've never met an idea I didn't like. When I would sit with people in this spirit, in the spirit of appreciating their experience, appreciating their perspective, and then not being judgmental about it, say, "Well, look, this is how I see the situation." In other words, just telling them, giving them an alternate view, maybe an expanded view, a view. And I say, when people are listening, people are listening to this podcast, they're going to walk away and they're going to hopefully take some ideas with them. I'm not teaching anything to anybody here. I'm not being didactic, but people are listening. And my mantra in life is everyone wants to live and be well, so that everyone is listening for opportunities to enhance their own lives.
Yes. Everyone is listening for opportunities to enhance their own lives.
Well, let's think this is a kind of a mind meld that takes place when one works as a psychiatrist with an individual, at least the way I did. I mean, I enter into the mind and the emotion and the world of the other. And in a way, because I always gave people access to me, in this interview, I didn't limit you to, I said, ask me anything, you're my most intimate secrets, ask me anything. That openness one to the other is a great start. And really, the questionnaire is, in a way, a threshold event in inspiring openness of the mother to the father to the mother, by asking questions that may never have occurred to them about the other. You know, if the father answers he doesn't feel he has an intimate relationship with his partner, and the partner gets wind of that, she says, "What do you mean?" And he says, "Well, I want to do more than just touch you." So, you see, uh, we have to keep opening doors, emotional doors. I would say doors that have to do with perspective. Even the idea that I talk about pregnancy as a threshold event. Threshold event. You step over the threshold into another world. Which reminds me, I brought my first acknowledged child home from the hospital, and, I'm standing outside my apartment, and I have a picture of myself there holding the child in my arm. My wife, was kinda hobbling by because she had a cesarean, and I'm about to go up the elevator to the 8th floor in my apartment. I'm standing there in front of the apartment, and someone takes a picture, and as they're taking the picture, I said, "OMG, what do I do now?" That was a
Right.
threshold event. When you actually bring the baby home, you're a mother, you know.
Oh, yeah.
But but
I think
but
that's a
but
very common feeling of
this
what do I do
happens to
now,
this happens
right?
to fathers too. I mean,
Yeah.
even saying this out loud, it's not like, well, mother brings the baby home. Well, wait a minute. The mother and the father brought the baby home, and not only does very this it's just in some way, life is simplified for the mother. She keeps her eye on the baby. It's more complex for the father. He's gotta keep his eye on the baby and the mother. So, this threshold event is, a little bit more complex than one might think.
Well, it's really difficult to prepare because oftentimes you can read all the books or do all the research, have the conversations, and it's not until you experience it oneself. Do you really understand what it's like?
It's like pregnancy. You know, your mother, father, but, this idea here we have our significant others, and
Yeah.
then the next thing you know, the mother gets pregnant. Well, every first pregnancy is a big surprise to the woman. Her whole body changes. A little changes at first in the breasts and maybe the sleep patterns and the morning sickness, but everything keeps changing, and then it keeps changing, and then it gets to the point where it's like, "I'm actually going to get this out of me. It doesn't make any sense." Babies are big. Babies are big, you know? So, in other words, these really are events. Being an obstetrician, when I started out, I delivered many babies, and at the time, we did have fathers in the delivery room if they were able, and for the father to witness this event of the baby emerging from his wife, that's, again, these are, experiences that have been, I would say, hidden from the world of couples for years, until the '60s. Father was never allowed into the delivery room. As a matter of fact, with my first child, the obstetrician didn't want me to go into the room. I had to fight my way in. I had delivered 100 babies or more. I was a psychiatrist. He didn't want me to come into the room. I fought my way in. I said, "I wanna be there," because at the time, I'd been reading a book by authors Klaus and Kennel. Now, and the title of it was Infant Mother Bonding, and the theory at the time was when the infant is placed in the hands of the mother after birth, and she gazes into the child's eyes, there is a bond that is formed, that's very, very unique, and so that was an important moment. My wife had a cesarean section. So she was unconscious when the baby was born. So I took the baby in my arms, and I
Yeah.
said I gazed into the baby's eyes. If you can have mother-infant bonding, you can have father-infant bonding.
Yeah.
It was deeply involved. Now, later on, it became through further research, maternal infant bonding was found not to be correct, but believe me, I was there trying everything I could to, make that connection with the baby, and I was doing it in a way in place of my wife who wasn't able. And, that idea of I was you might say I was a mother surrogate.
So regardless of what some books said, did you feel you bonded with your baby in that moment?
Absolutely,
Yes.
really I was carried away. But then what happened was because the, child, my wife had some, y renal difficulties before They were concerned that the child might have an infection, and that's another story that was traumatic because I had a
Mm.
special needs child. The first 10 days were spent with the child in an isolette, the mother upstairs, the baby downstairs, and me coming to visit and giving bottles to the child in the isolette.
Yeah.
So, I was developing my maternal bona fides,
Sounds
not a
like it.
real mother surrogate.
Well, is there anything else that you want to leave us with? Some final thoughts to share with listeners?
I think that the central word here is joy. There's joy in life when one has the skills to make it work, and not only the skills, but also the wherewithal. In other words, you have to have enough money, enough food, enough clothes, enough shelter, but there's joy. And so everything that I've been sponsoring, promoting, encouraging through my life as a psychiatrist has been by way of helping people to develop what they needed to experience the joy in living with their mates, with their children.
Thank you. That's a beautiful place to end. Thank you so much for your time today.
You're very welcome, and I can't wait to do some more, you know, in the hopes that someone listening might some way come away with something that's useful.
Absolutely. Thank you. I know we scratched the surface. We're going to have you back again very soon. Okay. Thank you, Dr. Ed Stevens. You can subscribe to this podcast in order to hear more from us. Thank you for listening, everyone, and I hope you'll join us next time on the Fourth Trimester. The theme music on this podcast was created by Sean Trott. Hear more at soundcloud.com/Sean Trott. Special thanks to my true loves, my husband Ben, daughter Penelope, and baby girl Evelyn. Don't forget to share the Fourth Trimester Podcast with any new and expecting parents. I'm Sarah Trott. Goodbye for now.
Hello again, bicycle man. I know you're doing all that you can. I wrote the song, simple and true. I wrote the song, I'll sing a song for you. You got your wheels, you got your gears. You ride around town without any fear. You got your pedals, you got your brakes. You always wear your helmet for safety's sake. Hello again, bicycle man. I know you're doing all that you can. I wrote the song, simple and true. I wrote the song, I sing a song for you. Hello again, bicycle man. I know you're doing the best that you can. I wrote the song, simple and true. I wrote the song, I sing a song for you.